So yes, again, thank you very much for coming and joining today to us. We will talk about today about the relationship, the effect of the implicit ontological assumptions on patients' experience. First, I will introduce myself, then Enise, you can introduce yourself. I'm a board-certified psychiatrist in Germany. I studied also neurobiology and also then came to Germany and did neuroimaging research and some affective neuroscience research. And recently, I began also research in phenomenology, especially the ketamines, or about the ketamine subjective experience. So, Enise.
Okay, thank you, Duygu. I'm Incesoy. I am a psychiatrist in training in Germany. I'm from Turkey. I studied medicine there, and yeah, I worked as a clinician scientist in Germany in different places, and yeah, research on schizophrenia and dementia, both in the both as disorders, but also for their early diagnosis and treatments using different neuroimaging and behavioral techniques. And yeah, since some years, I'm interested in phenomenology and also recently in active psychiatry. And lastly, I am collaborating with Köln University for an international dementia network. I'm happy to see some faces also from there. Yeah, I'm very excited for the talk, and thank you for being here.
Okay, now then I share our, so, So our title is Having a Psychiatric Disorder or Becoming to a Psychiatric Disorder. Of course, these two are the two polarities of this. What we want to examine is the effect of assumption about the ontology of psychiatric disorders on the patient experience. You can ask why should be important about talking about the ontology, especially for clinicians or for patients. We just do our practice. Especially if we consider that the diagnostic manuals, DSM, ICD claims that they are actually theoretical, even though actually they're implicitly accepting they are discrete disease entities. And these diseases can be identified through signs and symptoms criteria. And disorders are internal to the patient and they are mostly decontextualized. And also, of course, there are hidden assumptions about the ontology. Without it would be not possible to do any research. And the research is the dominant model is neuroreductionism, and in clinical practice, it's rather brain-based biopsychosocial model. And is it bad? Actually, not necessarily. We will talk about the problems and limitations of it, but we need these classifications. We need some categorizations, and this practical needs favor verification and translation of intersubjective experience between the clinician and the patient into standardized facts, because as a doctor, I have to justify the treatment. Why do I chose this, to the insurance company, to my colleagues who will follow me, and for also organizing all the psychosocial support. And also for research purposes, we need some operational diagnosis so that, especially now, considering that big data has gained so much importance lately, and obviously it will gain more importance, we need some operationalization, so this DSM ICD diagnosis. But they are useful for sure, but they also affect patient self-understanding. When we say that when we assume that psychiatric disorders are static physical entities in the brain, and it will helps patients to name and validate their suffering on the one hand, but on the long run, it reduces the identity. Sometimes there is this danger reducing the identity to the disorder. And often the unique and situated experience of the patient is underestimated. And often it's thought that the experience or the behavior has no meaning. It's just the symptom of a subpersonal process. And this might foster passivity and disempowerment. Now I will introduce some philosophical debates in the philosophy of psychiatry very briefly. It's actually much more, there's much more to tell, but I will only mention the most important parts. First of all, the first question is, what is it that is disordered? You know, psychiatric disorder, what is that is disorder? Can we reduce a psychiatric disorder to a brain pathology or other dysfunctions? Some people say that actually not anymore, but there has been times that there were reductionist models were more popular. There were neuroreductionism, cognitivism, or psychoanalytical models, but more and more it's clear that in a psychiatric disorder, many aspects of the human, the person is affected. And then these are pluralistic models. Like biopsychosocial model, I will now talk about it later more. There are certain dimensions, there are certain factors, but they are not integrated, but there are also other models like enactive model, network model, also focused on how these different dimensions aspects would be interacted to each other. And another question is, do psychiatric disorders exist independently of how we describe them? So if anyone, nobody would describe schizophrenia, would there be a schizophrenia? You know, realists claim that disorders are real entities. They exist independently. They would even exist even if we didn't name or classify them, since there are some neurobiological markers or findings for some disorders, schizophrenia, depression. And some disorders like schizophrenia show cross-culture consistency. But then nominalists say disorders actually categories are just human-made labels. You know, there is culture and historical variation in diagnosis. For example, hysteria was a popular diagnosis 100 years ago in German-speaking countries. But now, I'm a psychiatrist. I'm a psychiatrist since 12 years or something. I never diagnosed as hysteria. So, also there are cultural variations. For example, bipolar disorder somehow is very rare in Germany, because for the patients who could be diagnosed with bipolar disorder in Turkey or in USA are diagnosed with other disorders. And they say also there's been so much research about to find the biomarker, but nothing has been found yet, or there is this role of normative judgments. Another related debate to that, okay, if psychiatric disorder has a reality, because you can say psychiatric disorders are real, but not schizophrenia. So there is psychosis as a reality, but not schizophrenia. So it's also the discussion is also, what is the nature of psychiatric disorder categories? We classify psychiatric disorders, but what are they? What are these categories? Essentially, a strict form of realism say that actually psychiatric disorder categories are natural kinds. That means that they have an underlying distinct defining essence, so a core feature that makes it what it is, so that we can differentiate things from each other, categories from each other, so categories are distinct. And it's a medical model analogy like cardiovascular diseases or others, and it's basically the foundation of the biomarker research for diagnosis and prognosis prediction. But on the other hand, social constructivist says, form of nominalism, they are psychiatric disorders are actually structured, the categories are fuzzy, the distributing categories are fuzzy, and the categories are structured by social culture dynamics. In addition to what I said in the previous slide, an argument is that there is a weak heterogeneity within disorders. So a depression patient can be very different from another depression patient, but I can show you 10 different depression patients, maybe they will have nothing in common, you know? And there is the high rates of comorbidity. You know, if these disorders are this thing, why is the rates of comorbidity so high? So, and there is this looping effect. So if you diagnose a person with a disease, with ADHD, for example, the person is affected by it. And these people who are affected by it eventually affect the diagnostic criteria. So there's a looping effect. So this is the two polarities, but there is also other ideas that we can place in the middle, like mechanical property clusters or homeostatic property clusters. They say, okay, categories are kinds, yes, they're close to nature kinds, but they are not so distinct from each other, but they are structured by nature, structured by a biological causal mechanism. Another form is that practical kinds. There are people who are defending practical kinds. It's a form of nominalism. Actually, diagnostic categories are made for pragmatic reasons, but there is no commitment to underlying mechanism. The distinction is fuzzy and reason is practical. So if we then translate it to the patient experience, when we say psychiatric disorders are solely brain disorders, when we have a realistic, essentialist, objectivist also important, saying that diagnosing a psychiatric disorder, saying who is normal, who is not, is based on objective facts. So, of course, there are people also such as support defending that actually they are value-based. But if we say that everything is biology-based, everything is based in brain, and what would the patient think? You know, I'm not the one who is my brain is. On the one hand, it's good. It's a relief in the beginning, less responsibility, less guilt and shame, less stigmatization has been actually claimed that it will be less stigmatization. But is it actually so? Because the patient then has less agency than disempowerment, which can in turn, and there are some studies showing that could be lead to more stigmatization because they would be disempowered. And there is no meaning, as I said, in subjective experience, then the patient would would seek only symptom release. And also his stance is to the disorder, his relation to the disorder would be also meaningless. And we mostly also in the clinics do not ask to the patients, what is the meaning for you to have a schizophrenia or depression? And if we say that these disorders are distinct and from each other and distinct from the normality, it's also causes some isolation for patients. And then the reaction to this, Engel proposed a biopsychosocial model in 1977. It's a pluralist and a non-essentialist view, and acknowledging there are other factors important in psychiatric disorder. But as Kendall said, it's very useful for clinical and teaching functions, definitely, but it lacks this philosophical coherence. It's agnostic about the nature of categories, actually. And it's rather additive than interactive. And experiential and existential dimensions are not included. And in the practice, the factors, for example, social worker treats the social part, doctor treats the biological, psychotherapist is the psychological part. So we target each factors separately. Now, Enise will go on with another pluralist model, but an integrated model with an active model.
Yes, I will talk about an active psychiatry. If you remember one of these first slides, actually there is this one single aspect models, and there are pluralist models, and under the pluralist models there are non-integrative models, and there is integrative model. And an active psychiatry is one of these integrative model. From this perspective, psychiatric disorders are not just disorders of the brain or clusters of symptoms or social constructs. They are disruptions in sense making. You will hear the sense making many times while I'm talking about enactive psychiatry for the next 15 minutes. And so like the psychiatric disorders are disruptions in sense making across 4 dimensions. Physiological, yeah, you don't see my mouse, but like the physiological, experiential, socio-cultural, and existential dimension. I will come to this for dimensions, and sense making in the enactive psychiatry can be understood as embodied, embedded, and existential cognition. You will hear also what these terms mean. The unit of analysis in enactive psychiatry is, as I said, not brain or not just symptoms or not social-cultural constructs, but the person in their world. This term is like coming from being in the world, Dasein, from Heidegger, and that says that means the bodily and reflexive beings as agents in interaction with their meaningful worlds over time. You see here the book that is that I am based on now on my presentation, and Sanake Dehan is one of the most important figure in this field, developing the enactive psychiatry very systematically. She is a philosopher and she has long-term experiences in the psychiatric hospitals. And of course, Sean Gallagher is another person who develops enactive psychiatry very much. Next, please. So here we see the 4 core dimensions of enactive psychiatry: the physiological, the experiential, the social-cultural, and the existential. You see them here as separate circles, but actually I want to invite you to think all of them as part of one whole system. But of course, for the sake of understanding, for the sake of researching, for the sake of talking, maybe we separate them. And the physiological here refers to all bodily processes involved, from genetics and hormones to neurocircuitry, the movement of the body. Much of this happens below conscious awareness, but it shapes our capacities and vulnerabilities. And experiential dimension here refers actually to phenomenological, the subjective experience of the person living with psychiatric disorder in the enactive psychiatric sense, what it feels like to have a psychiatric disorder. It is both the starting point and the ultimate target of the treatment in the psychiatry. Even though you are not a phenomenologist, you will listen first what the person says to you, how they feel like. They will not always come and say, yes, I have this and this and this problem. I have a depression actually, and you can give me this medication. But they will come and say, yes, it feels like yeah, I don't have the energy anymore, and I can't get out of my bed, and I can't sleep. Like, they will talk about their complaints, and most of the time very much from the first person perspective. So the next dimension is social-cultural dimension. It includes the broader world we inhabit. It's not the environment in the basic sense, but also it inhabits our norms and roles and expectations and relationships. And mental sufferings, as you might already know or think, is always embedded in and shaped by the social fabric. And they can't be taught. Taught outside of the social cultural world. And the 4th dimension, existential, refers how we relate to our lives and here in this enactive psychiatric sense, our psychiatric disorder, our stance towards this psychiatric disorder. Okay, so I have these problems and the world seems meaningless to me, or so I have dementia, and maybe in dementia you will lose the existential stance as important symptom of the disorder. Importantly, as I said, like, there are 4 dimensions, but none of these are foundational, underlying, or more real than the others. They are co-constitutive dimensions of one and the same dynamic system. However, this also does not mean that there are there aren't any differences between them. We can distinguish between more local and more global processes and interventions. Like more local, I mean the physiological ones, like how the brain neurons fires, or the global ones are more this experiential and meaningful parts, but they are both important and part of the same system according to enactive psychiatry. For example, if we take anxiety, a bodily response like increased heart rate, the physiology, may be experienced as overwhelming experience, which is interpreted through some cultural norms. Yes, I shouldn't show fear in this condition, and shapes one's existential stance. I'm failing and I'm not safe. And these dynamics form a self-reinforcing pattern where symptoms are not just outcomes, they also become part of what sustains the disorder. That's why enactive psychiatry uses the idea of organizational causality. Changes in one part affect the whole system, and the system as a whole shapes what any part means or does. So the next slide, I will try to talk about enactivism very shortly. Actually, to be able to understand enactive psychiatry, we should understand enactivism and its concepts. Especially sense making, as I said, is very important. According to enactivism, cognition is not information processing inside the head, but a form of embodied sense-making, the ongoing adaptive activity of a living being in relation to its world. As you see, I always talk about the living being and the environment and their constant relationship. So cognition emerges through this dynamic relationship. It is embodied. It means it relies on a body with needs, habits, and motor capacities. It is embedded. Those capacities develop in a cultural, social, and historical world. It is affective. We never encounter the world neutrally. When we perceive what matters to us so that we can act upon. So the next slide, so inner-outer division of mind and word is rejected in enactivism, and this is very important ontology of the enactivism, which brings also this pluralism in the integrated sense. The organism and world are dynamically coupled, and this is because of the very constitution of the living beings. As living beings, we are not just the accumulation of non-living aggregations of the matter. We are so living beings rely on a constant exchange with the environment in order to maintain themselves. For their own survival, they need to make some sense of their environment. When I perceive something, I already perceive the danger or the relevance of it. If I am hungry on that moment, I already perceive things which are possibly eatable for me, or if I am in a danger, I also perceive the world accordingly. It is not an extra added cognitive effect, but we already make sense of the world. And this sense making interacting with its environment called cognition in enactive psychiatry. So in living beings, the matter, these physiological processes, and cognition, these psychological processes, necessarily go together so that mind and life are continuous. This life-mind continuity thesis argues that matter is not opposed to cognition, and that matter in specific organizations can give rise to a qualitative difference. And this brings us to the notion of emergence. You can go, Duygu, one more. Yeah, the properties of the whole depend not only on the properties of the parts. This is very important for the enactive psychiatry, but also on their organizational structure. So this relationship and how they organize themselves is important. So it's not just the accumulation of neurons. Our brain has this organizational structure. So our body. The whole is more than the sum of its parts. Thus, emergent phenomena are irreducible. And yeah, I mean, I think we can continue on the next slide. And I will also pass because of the time, I think. So it is very important, the affordances, because sense making is the cognition, sense-making, this adaptive interaction of the living being with the world is neither passive information absorption or information processing, nor active projection. It is a relational function. And the enactive approach is grounded in this very relational ontology. This means that reality isn't something that exists independently of me outside. Instead, it emerges through the ongoing relationship both within the organism and between organism and environment. These are not just external interactions for me. They also actively shape what the organism is. You can imagine a bat has a different world than me, but it doesn't mean that we have different worlds or we are just constructing this world inside our head. But we experience and perceive and make sense of the world according to our possibilities, our perceptive or bodily possibilities, and what the world gives to us. So this relationships, also the world we live in is not simply out there, but co-emergence with us through embodied sense making. And yeah, to understand sense making, we should look at the whole organism in its environment. So we look at the enactivism now, and I will talk about the existential dimension. You can go. All organisms, as I said, relate to their environment, but only humans relate to this very relation and themselves. That makes us different. We are existential living beings because we relate ourselves, how we live, how we make sense, how we care. And this capacity is called existential stance taking. It is a qualitative shift that transforms an organism into a person, not just embodied, but also self-reflective and socially embedded. We don't just eat to survive, for example. We eat in ways that reflect identity, culture, and values. We fast, or we are vegetarian because we have some values, or we eat meat for another reason. And you can think about all your habits in your daily life from this perspective. We never only do things to survive, but they matter to us as well, and they show and co-constitute also our physiology, because then how we act will affect our physiology, and it is shaped by what matters to us. So this marks a shift from basic sense making, what the enactivism tells, to existential and existentialized sense making, implying the emergence of values for the people and of socio-cultural worlds, and at the same time depending on this world for its development. And this existential stance is not just added on top of all these three dimensions, but it reorganizes the entire system from an organism environment into a person world structure. We are not anymore these organisms having basic sense making, but we are persons in the world whose existential stance already shaped all the physiological, phenomenological, subjective experiences. It is this existentialist sense making of persons in their world that goes astray in psychiatric disorders. And this is a key precondition for psychiatric disorders, because only beings who can take a stance toward their experience can suffer in this personal and existential way by maybe comparing their condition with their past or with other people. I need to take a stance and look at myself and see, okay, there is something wrong going on here, and then I might take a step towards psychiatry or any medical or any help. So, but it's also very important to differentiate existential stance as they might have different roles in the psychiatric disorders. They are not, the existential stance is not always affected similar, same in different ones. First, it may play a constitutive role in the disorder. This is, for example, the case in anxiety disorders, where the fear of getting a panic attack is already an inherent element of the disorder itself. And secondly, existential stance can be affected by the psychiatric disorders. For example, depression not just affects our mood and energy and sleep, but also affects one's reflective stance on things, it is part of being depressed to have no hope for future change, to have a distorted perception of the past. And as third, the existential stance might have a modulatory role in the psychiatric disorders, because how patients relate to their diagnosis, and this is our topic, right, to their treatment and to their disorder can significantly shape the course of the disorder. If I take my disorder only as a brain disorder, then I might actually not need to have a look on my existential stance, but actually if I see that in a bigger integrative system, I will also see that actually how my existential stance is important to realize my psychiatric disorders, and how this existential stance contribute to my disorder. And actually this same existential stance might be the source for the change. So the enactive approach overcome, next slide, the conceptual dichotomies that have long divided psychiatric theory in different perspectives, such as realism and constructivism, as Duygu discussed, objectivism, evaluativism, internalism, or externalism. From the enactive perspective, psychiatric disorders, and it means disordered pattern of sense making, are both real and co-constituted by the socio-cultural context. In that sense, enactive psychiatry is also nominalist, because they take the psychiatric disorders as real phenomena, but they are definitely co-constituted, not just affected, but co-constituted by the socio-cultural context. Our world is not a passive background setting, but a part of the system, affecting our physiological processes. So psychiatric disorders don't become real only through our classifications, but their disorderedness depends on their context and the prevailing norms, like the hysteria phenomena. We have similar hysterical patients. They have now different names for their diagnosis, but we don't diagnose anymore hysteria. But there is something behind these categorical categories. So these disordered patterns of sense making, meaning psychiatric disorders, are not referred to static, universal, or never changing natural kinds, but rather emergent phenomena. They have a specific embodied and an embedded perspective depending on affordances of the person in a specific context. In enactive relational ontology, the boundary between internal and external dissolves, and what seems internal, like genetic or neural dispositions, is itself shaped through ongoing interaction with the world. Rather than locating causes inside or outside, like traumatic experience outside and genetic thing inside, the focus shifts to understanding this dynamic person-world system as a whole. And activism, therefore, offers a way to reconcile universality and uniqueness. Shared structures of disorder exist, but each person's trajectory is shaped by their specific history, body, and world. There is no contradiction between typology and individuality. And crucially, treatment shifts. It is not about fixing a part, a brain, a body, or a family relation. It is about helping someone reconfigure their relationships to their body, to others, to meaning. Our capacities are enacted, not possessed, and they emerge in the right context. That means treatment must address not just the individual, but their niche, the space around them, the support available, and the values that sustain their sense making. So enactive psychiatry invites us to care for persons, not isolated symptoms, in the fullness of their person-world system. So if we look at the next slide, please. If we look at the 4 dimensions, we might put the psychiatric disorder in the middle of everything. I couldn't put it in the middle, but think about psychiatric disorder in the middle. Because having a psychiatric disorder often brings one's very sense of self into question. Is this me or the disorder? What can I still trust in my experience? how someone relates to their disorder can deeply affect how they feel about having it, ultimately how it unfolds. This is not just a private and internal matter. Narratives from family, clinicians, and society shape how someone makes sense of their condition. And this is again relevant to our discussion right here. So how the clinician sees the disorder will have an even constitutive effect of the psychiatric disorder emerging in the person. Even treatment itself involves existential stance. Whether one chooses medication, psychotherapy, or movement-based approaches, for example, often depends on how they relate to their suffering, identity, and hope. Moreover, existential stance is not just something that is disrupted, it is also the very means through which transformation becomes possible. So the enactive approach reframes psychiatric disorders not as isolated entities someone has, but as disruptions in embodied, embedded, and existential stance making. When patients come to see their disorder as spanning across these physiological, experiential, sociocultural, and existential dimensions, they are no longer merely passive recipients of a diagnosis. They gain agency. And this allows them to recognize how sociocultural norms shape their experience and how their own values and context influence the course of their disorder. It may also impact physiological processes because mind and body are continuous. Reorganizing one's relation to meaning, environment, self, and others can feed back into body regulation and affect the course of the disorder itself. In turn, this empowers them to respond differently, to challenge harmful patterns, to engage differently with others, and to participate actively in treatment. In short, ontology of psychiatric disorder matters. How we understand psychiatric disorders shapes how people live with them and how they recover according to enactive psychiatry. You are
okay.
Yeah.
Thank you, Enise. Now we will do a kind of conceptual jump. So recovery model. We will now give an example of how the modulation of existential stance can change the experience of the patient, can change the recovery process of the patient. So for this reason, we thought recovery model could be a good example of it because it cultivates an empowering existential stance, emerged in 1980s, largely as a reaction against the institutional, pessimistic practice of psychiatry, especially toward people with severe and chronic mental disorders, and change how the patients related to their disorder existentially by emphasizing meaning-making capacity of the individual and giving right to agency, identity, and self-definition, especially primacy of the subjective experience, because criticizing the assumption that psychiatric patients are epistemically compromised for this reason, subjective experience is not important. And also, of course, the biggest contribution is that psychiatric patients can live a meaningful life, can aim a meaningful life with or despite symptoms or due to thanks to the symptoms. And in recovery model, recovery is it's not about symptom recovery, it's about having a meaningful life, and it's dynamic, nonlinear, a personal journey, and it shows that recovery-oriented practices promoted personal recovery even in severe mental disorders. Then what can enactive psychiatry bring to recovery model? On the one hand, it is would many people proponents of recovery model wouldn't like that somebody is theorizing bringing some ontology to them, because the emphasis is especially on the individuality and complexity of the experience of the patients. And but it's also criticized that because of this lack of overarching theories, it's very hard to do studies or research about recovery. And it's also very hard to relate the different dimensions of recovery to each other. And enactivism might offer an ontological foundation because, as Enise said, as the world and biology shared, there are patterns, there is universal patterns, there is shared sense-making patterns in society. But at the same time, as sense-making is embodied, enacted, so it's very individual. So where recovery demanded empowerment and meaning-making, enactive psychiatry shows why these are not just rights of the patients, but ontological necessities for recovery. So then we can say, as Brian, a psychologist from Holland, so recovery of being in the world through participatory sense-making. And I think it's a good, so again, the recovery proponents, some of them would not like this. It's not participatory, that's more the power of the defining the meaning of the disorder should be in the person who is affected. But on the other hand, we can discuss in discussion part, the clinicians or mental health professionals has also, of course, to offer to people who are affected. So participatory sense making is very important. So I think we talked about it a lot now, Enise. It will be a bit.
No, but I think it's important. Let's finish with this slide.
Okay, then
we have still 5 minutes time.
We have another slide, you know.
Okay, yeah, but
Yeah,
maybe yeah, very shortly.
Okay, so then if we summarize it, but as again, it's a spectrum, but we give two perspectives. If a patient, if we have, and also the patient or the society has a assumption that actually psychiatric disorders are things that with an objectified pathology and dysfunction that one possesses, that one has, and can be extracted like cancer or something, and individuals are vehicles of these pathological syndromes that would promote, of course, a symptom-focused treatment, and it would promote a passivity and externalization of responsibility and fragmentation, what Enise mentioned, between the illness and the self. And for some patients, then the whole process would be the desire to return to a pre-morbid normal state, or for some severely chronic patients, a fixed identity as a sick person.
Yeah, but on the other hand, disorder of the person in the world, this idea will show that the disturbance in sense making of the person is the psychiatric problem. And it's a dynamic process. It's not static. It's not just a reified thing. And it's rooted in phenomenological and enactive psychiatry. I didn't focus on the phenomenological side, but of course, Thomas Fuchs is also very much inside of this enactive psychiatry, and all this phenomenological part is very important part of the enactive psychiatry. So the person is not separate from the disorder, but rather experiences and enacts it through their whole mode of existence in the world over time. So this approach, disorder not having, but becoming or experiencing and enacting, promotes the self-understanding and meaning-making, and therapies offers therapies that support integration and transformation, so that the people don't go to their previous stance, but actually become with disorder as someone new.
So as a last slide, I think that's also very important to mention. In the end, these are all models. So this human experience, human and patients and human, we are very complex. And what is actually needed in the awareness of the assumptions that we have and how we can improve them, you know. A conceptual awareness, conceptual competence, and conceptual humility that the current psychiatric knowledge is partial and provisional in nature. And actually, the contradictions between the models, we should not react with an epistemic horror, but rather we should embrace it with curiosity. I thought about this before the presentation. because how would patients be interested about it, you know, about the ontology of psychiatric disorders? And the many people came into my mind as friends or patients. They trust mental health professionals, that they think about it, that they actually know about it and at least think about it. If I would say a patient that we are discussing it, he would say probably, don't you know already, you know? So we should be aware of it. We cannot solve this, but we should be aware of it. And we should be at the same time aware of the variety of goals of psychiatry that we mentioned in the beginning. And that psychiatry, mental health practices is practical. It's a system that we need to decide always in uncertainty, you know. But it's also, now we actually try to show, and I hope we managed it, the assumptions that we have about ontology is actually affecting the patient's existential stand and the whole process of the disease. So that's also very important for this reason, that there is a co-production between expert and experience, and expert and training, that the expert and experience are more involved to the process. So thank you for your attention. We are very excited about hearing your suggestions and questions. I would just one moment, so I would suggest that if you agree,
Duygu, would you please stop the recording?
Yeah, that's, should we stop recording? I think that because this topic is really open to discussion, and I think the discussion can be also very valuable. But of course, it depends on if people would be disturbed by it.
I would suggest to stop it, because this is how we do always. I think the discussion is always nice, but I think, yeah.
Okay.